days.
Yeah. Yeah. Got it. Okay. No, this was helpful. I'm trying to think if there's anything else I can ask. I think this was definitely very helpful. Do you any of the cost dynamics that you described, would those be potentially different at like an ambulatory care center or outpatient facility?
It depends on if it's freestanding versus associated with a hospital. If it's associated with a hospital, the cost structure would virtually be almost identical, though the facility fee is somewhat slightly higher at the return on investment, ROI, at a freestanding surgery center is probably higher because of the bureaucracy and the overhead is probably lower. I don't think you're going to get I don't think most people, because I run 5 different surgery centers. I manage the anesthesia department. And what I'm told is that, they want to maximize profit to the most that they can, and so maximize patient referrals by essentially keeping patients happy, making sure the patient satisfaction scores are very high so they get referrals. So if something is going to decrease the amount of pain these people have and increase their satisfaction, most freestanding surgery centers will go ahead and do it. Most plastic surgeons, when they have these augmented mammoplasties, breast augs, they use Exparel. And they tell these patients that they're going to have to pay an extra $300 or $500 for the drug. It's a function of patient expectation and then patient understanding. So at a outpatient surgery center, it's more so that they're going to use IV meloxicam, because if they find that it really is better than IV Toradol and decreases pain, they're more apt to use it, and they'll charge a higher rate for the procedure because they can.
Mhm. Got it. Okay. And then I guess any apart from clinical efficacy, the frequency of dosing, the fact that you can give it through the night and beyond, and that will improve quality of life or quality of care while you're within the hospital setting for a patient, so they don't have to wake up every 6 hours to get new drugs. How much credence did you put behind that idea? Meaning that might be a good reason for it to get adoption or to be used widely, or does that not really matter?
Honestly, it does not matter whatsoever, because these drugs are IV. So the patient doesn't really have to wake up. The nurse goes in, hangs a new drug, programs the infusion pump, and they're done. The patient can remain sleeping the whole time.
The nurses don't need to check vitals when they switch out the drugs, for instance?
They check vitals every 4 hours, but most of the time now the vitals are done automatically. The way we do it is that these patients wear a blood pressure cuff and pulse ox and EKGs the whole time, so it's done automatically. And if it's done automatically, if a patient's sleeping, their brain just doesn't respond to it. The nurses aren't doing the vitals. We do it automatically via a remote monitoring.
Mm-hmm. Got it. Okay. The company did apparently surveyed like 600 healthcare providers, and 30% of them, close to 30% said that they would use this product as opposed to either Teralac IV Motrin, IV Tylenol, or opioids.